Hello, everyone, and thank you so very much for joining us on today. We're here to remember someone that could have been your aunt, your mom, your sister. We thank you all for your attendance on today. There are no affiliations that are tied to the speaking engagement on today. If there are any affiliations, they will be stated. Dr. Susan Moore, we say your name. Today, we talk about the untimely tragedy of her death, racial disparities, and the ethics behind them. Dr. Susan Moore, we say your name. I want to take a few minutes for us to just remember her in silence. Thank you so very much for that. If you're listening to us from Clubhouse, remember that Clubhouse is a podcast. You won't be able to physically see us there, but you'll be able to see us, feel the impact, and understand the message. If you're listening to us from YouTube and you have questions, please drop those questions down below, hashtag Dr. Susan Moore. If you're visiting with us on today via Zoom, please drop your questions in the chat feature that's to your immediate right. We thank you so much. I am Dr. Taaka, one of the facilitators of this conversation. I sit amongst beautiful brown and black bodies. My colleagues, they will introduce themselves. Dr. Eseosa, I yield the floor to you.
Thank you, Dr. Cash. My name is Dr. Eseosa Ighodaro, and I'm a neurology resident in my second year and a neuroscientist. We are conducting this panel because we want to keep her name alive in the media and not let her death be in vain. Thank you. Dr. Ima.
Good afternoon, everyone. My name is Dr. Ima Ebong. I am a neurologist and I practice in academic medicine. While I am saddened that we are here to discuss this topic, I'm grateful to see so many people here in Zoom and others in Clubhouse and on YouTube who want to learn more about this topic and who want to keep Dr. Susan Moore's name alive. Thank you.
Dr. Campbell. Dr. Campbell.
Hi, how are you? My name is Dr. Linelle Campbell. I am a PGY4 emergency medicine resident. And I just want to say thank you for having this space. I think it's a very important topic. So I'm glad to be here contributing to the conversation.
Alima.
Hello, everyone. My name is Alima Jackson. I'm a recent master's graduate with a degree in medical physiology, and I also work as a nurse. I'm one of the founders of Aspiring MDs, on the club on Clubhouse, which is facilitating this room tonight.
Dr. Nafi.
Hello, everyone. I'm so honored to be in this space. My name is Dr. Nofisat Almaroof, and I'm a board certified family medicine physician. And I'm very, very, very honored and excited to be in this sacred space to talk about Dr. Susan Moore.
Jessica.
Hi, everyone. Good evening. Thank you or afternoon, depending on where you are. Thank you for joining us. I'm a community psychiatrist and also a medical educator who is involved in the training of psychiatric residents. I'm very glad that the space was created to have this dialogue. Nice meeting you all.
Thank you, Dr. Jessica. Edo.
Hi, my name is Ito. I'm a recent graduate from Hopkins University, and thank you all for joining us. I think it's a really important discussion for us to talk about, and I appreciate you guys' presence.
Dr. Chery.
Hi, everyone. I am Dr. Magdala Chery. I'm a board-certified internist and currently in training for minority health policy. I am honored to be here to take part in this discussion, and I think there is no better way to pay respect to someone who unfortunately had to document her death than to say her name, share her story, and discuss how we can make this different for someone else.
Casa is a student resident who is also in the Clubhouse medium, and he is actually navigating the audience that's over on that particular medium. He will not be here in this particular space, but we want to make sure that we acknowledge all of our facilitators that are giving their level of contribution on today. Dr. LaShonda Hill.
Good evening, everyone. Did you want me to go ahead and do the disclaimer?
I want to make sure if I haven't missed, are there any other moderators that I may have missed?
I'm here. I'm having some video issues. My name is Tori Owens. I'm a medical student at the Philadelphia College of Osteopathic Medicine here in Philadelphia, Pennsylvania. And I'm also just kind of honored to be here and be able to contribute to the conversation about Dr. Susan Moore.
Thank you so very much for that.
Hi, my name is Dr. Erica Littlejohn. I'm also having a few video issues, but I'm a neuroscientist and I'm trained in traumatic brain injury and neuroplasticity, and I'm honored and grateful to be a part of this conversation as well.
Okay. Are there any additional moderators? Dr. LaShonda Hill, you have the floor.
Good evening, everyone. My name is Dr. LaShawn Hill. I am a family and psychiatric nurse practitioner, and I'm going to read a disclaimer today just because a lot of the information that we will be talking about today will be very, very sensitive, and it may be very triggering for some people. You should consult your physician, psychiatric provider, psychologist, or other healthcare professional to determine if this space, if this room is right for your needs. This is particularly true if you or your family has a history of trauma, as some stories can trigger unwarranted emotions. Do not enter this talk if you feel that you may be triggered. This story that we're talking about today is very, very sensitive. This site offers mental health, education, and psychiatric resources and information designed for educational purposes only. You should not rely on this information as a substitute for professional advice, and it does not replace your psychiatric or mental health provider. You should not mistake this information for medical advice, diagnosis, or treatment. If you have any concerns or questions about your mental health, you should always consult your psychiatric team. Do not disregard, avoid, or delay obtaining mental health or health-related advice from your mental health care professional because of something you may have heard or read on this site or during this talk today. The use of any information provided on this site is solely at your risk only. No assurance can be given that the advice contained in this site will include the most recent finding or developments with respect to the particular material. Certain mental health and medical material on this site in this room that we're talking about today may be sexually explicit or even taught with certain languages that may be offensive to others. Please do not use this site if you would find that this material and language may be offensive.
And in addition to that, there will be some licensed and credentialed providers and therapists on this panel. We do not offer services via social media platforms or through informational dialogues and messages. This is for informational, educational, and awareness. Information relayed through these informational dialogues does not take the place of medical advice. Let's open the floor up for dialogue. Dr. Esse?
So one of the reasons for us creating this panel is to process and to heal. So as a Black female physician and scientist, when I heard the news and read the articles and watched her video and heard her voice, I was speechless. Speechless in that someone, a human being who is suffering, goes to the hospital and all she wants is for her health providers to help alleviate her suffering. She didn't get that. And there are several Dr. Susan Moores, unfortunately, in our healthcare system. So I really want to come together and figure out how we can prevent Black bodies from suffering and pain in the hospital setting. So that was my initial.
Excuse me. So we have a question that came in from Caliph Wilson. It's a pretty large question. I don't know if you all would like to respond to it. What are the immediate, tangible actions that we can engage to protect Black women and Black people from dying and being harmed by medical racism? Hashtag Dr. Suzanne Moore.
I think one thing that we can do is speak up and keep her name in the social media, keep her name on the forefront, keep her name 24/7 in the news headlines. We cannot forget Dr. Susan Moore. We cannot forget until there are no more Black bodies that are suffering in pain in the hospital. So I think that's the first thing that people can do is have these conversations.
I think an important part of that question that needs some distinction is who are we directing those targeted actions towards? As someone involved in medical education, for example, my work around medical racism is targeting learners and also those people who are considered faculty and practicing right now. There's also tangible actions that could be directed towards people who are accessing the healthcare system, and those would be a little bit different. So for me personally, the way that I engage using most of my time is around engaging actual practitioners and acknowledging the history of medical racism, arming them with the data to support that it's a reality, and then addressing some of its manifestations in the clinician-patient relationship. So when I offer talks or offer trainings to practitioners, that's what it's focused around. And those tangible actions could be as simple as, again, acknowledging that it's something that exists and that you are complicit in it, and that these are the things that you should be doing to modify how you practice accordingly. So your complicity is at least reduced. It may not be reduced all the way because you're existing within a system, but it could be reduced from the level that it is right now.
Another question that I wanted to ask the panelists is, when you first heard, read, or watched the video of Dr. Susan Moore, tell me what was going through your mind?
When I first heard the story, it's sad to say I was not surprised. I actually was surprised this is the first time we've heard of something like this, because in my mind, even before I heard her story, I was pretty sure that there were similar stories out there. And the reason why I said this is I think Dr. Nafi kind of alluded to it before she was cut out. As a Black resident physician, I experienced something similar when I was giving birth to my child, and that my pain was not believed whatsoever. And they left me in a room by myself in labor, and I kept telling them the baby was coming. And I kept telling the nurses, I feel like I'm going to poop, that baby was there. And they didn't believe me. They said, oh, you just got here a few hours ago. Nobody examined my cervix to see where he was. And when they finally did, he was already crowned, and it was too late to get an epidural. And I gave birth to my son. I mean, I'm a strong Black woman. I gave birth to him without any medication because I had to. I had no choice. But I remember feeling angry. And I told my husband that as a resident, and I was a physician, they knew this, and they still treated me that way. And I gave birth to the hospital I worked in. So I had a similar experience. Like we said, not dire, I didn't die. But imagine non-physicians. Imagine other Black bodies who go through similar, no one believes them. And that was the first time in my adult life where I felt that, you know, I'm a physician, yet I'm still being treated like this. And not to say that I should be treated any differently, but it just made me realize how badly that our people are treated, and I know it's because of the color of my skin. And I know that's why I was treated that way. And I'll never forget that. So like I said, I was not surprised. And I was just thinking that there are other stories like Dr. Moore's, but she had the foresight to document it so that we won't ever forget it. And that's why we have to continue to say her name, because she wanted this out there. And she used her experience to teach us all how to do better as physicians, because we're all complicit in this. Although we're Black women, Black men in medicine, we're still in this field. We have to change it.
And I don't know if Dr. Nafi, if you wanted to finish, but I can also go.
I don't know where I cut out, but pretty much I think Dr. Ima, she did a great job in just saying that, you know, this is not news to us, you know, like once you strip plain clothes, that's it.
Yeah, I definitely agree. And I was at a friend's house for New Year's Eve, and it was just a few of us, no worries. But you know, one of my good friends, Chantel's roommates are white, and we were having this conversation. First of all, I feel like we're the only ones that know about these things when they happen, because I mentioned the name, and he's like, who is that? And I'm like, wow, like that's crazy, because this is a huge case that's been circulated throughout social media, but it's all about like about who you're, I guess, connected to and who's like in your social media realm, because they didn't know about that. And then we started going back in history, and they didn't know about HeLa cells. So it was just like, and then the denial from the other side that this exists. It was so hard to even have the conversation. And I'm trying to like listen. They're saying, oh, we don't treat our patients, you know, different, because these are residents that I'm talking about. And they're saying we don't treat our patients differently based on race. And there was another one who was saying, well, actually they do get, and the outcomes, you know, show that. So it's like, I don't know at what point do you like, have you said it too many times and where the person is just not going to change. And this is like a PGY1 surgery resident. So it's like, if that thinking is already there now, like how, you know what I mean? How can you continue to educate down the line?
Yeah, so for me, I mean, I definitely felt very helpless when it happened. You know, part of me is very exhausted with, like, I'm tired of hearing these stories, and I'm tired of, you know, there was a Twitter thread the other day about highlighting this, right? It's, you know, I'm very thankful that it's on social media. You know, this is one of the things that, you know, how we want to use social media to kind of make sure that these things don't go, oh, well, it was hearsay and we don't know if that's really what happened. Like, there's actual documentation, there's actual video of her talking from her hospital room. So you can't deny it anymore. And I think, you know, it's one of these things, like I said, I'm exhausted with it, but at the same time, it's, it's motivating, to say, well, it's no longer just people's subjective thoughts about, oh, well, I think they were being racist to me, like it was outright. We see what it was. And also, just as a Black physician, I think it's also very, I don't know if humbling is the right word to say, but it's just like, no matter how many letters you have after your name, no matter what credentials you hold, in a lot of spaces, people see us all the same. That means absolutely nothing. Those offer no protections for us. And so because of that, I think that's even more reason to sort of, like basically turn over this whole system that we have to really address. And we have to start holding everybody accountable, ourselves, all the way from administration to community leaders, all of these things, because it's not just going to happen, from a physician, right? It's going to happen. It has to happen at every single level from all the stakeholders, because we're going to lose this fight. And we're going to start seeing more and more stories of this. And we're going to start, part of me is like, I hate the fact that we even have to have this, right? I wish we didn't have to have this, but but unfortunately we do. But I want to get to a point where we're no longer saying, oh, another physician or another Black body or another, person of color is this, and we have it documented. Exhaustion is the one word that comes to mind with this. It's exhausting. That's all, mentally, emotionally, and then having to show up to work, the next day for me, and have this conversation with, an attending who's like, are you sure it was about racism? And so my question to him was, what else could it have been? Tell me, what else could it have been, right? And, and I know we're going to talk later on about the statement that was made. And, it's not even about what actually, it's about what happened, but then also how it's talked about and the words that are used to describe these patients and how we talk about patients. So exhaustion is my word, but it's also motivating at the same time.
Yeah, I agree with you, Dr. Campbell. I definitely felt the exhaustion. Initially, I felt triggered, if I'm being completely transparent. Many may know my story. I lost both my parents to COVID. So I didn't watch the video initially. I saw a thread that described it, and my heart immediately sank, especially when it talked about her documenting. The triggering comes from my father. So my father was in the hospital. He too died, not from COVID. I don't call it. I say he died from racism. He wasn't properly monitored. And he's not a physician, he's an immigrant. And I think when I read her updates, I saw my father. He kept telling me that. He'd call me from the hospital saying, they don't come into my room. They don't acknowledge my pain. They don't give me water. Come get me from the hospital. I'm going to die here. And I don't want to die here. So I could not watch her video initially. I started to, and I would stop. And every time I would hear a complaint, I would picture my father's face. And interestingly enough, what her video did for me is I've been living with guilt. I've been wondering, did I take my father to the right hospital? Should I have let him die at home? Because I know what system we have. I know what healthcare looks like. We can't talk about it as we work in the system, right? And we eventually we're looked at as traitors after people have no idea what we're trying to fight on the inside. And I've for 8+ months, I've sat with guilt. I said, I knew this system. Should I have taken him to the whiter hospital? Should I have called the front desk one more time? Should I have stood outside and fought for his life even louder since I couldn't be inside? So what her video did for me was say it didn't matter. She's a physician. She could articulate herself even better than my father, and her life didn't matter. And they treated her just like she was a Black body. So this fight is even bigger than just honoring my father, bigger than just honoring Susan Moores. It's saying that our system was not created with us in mind. It wasn't created for us. And then I was upset. And the upset came from, I went through Med Twitter. I wanted to see who was talking about it. And almost every time it was a doctor of color. Almost every time it was a Black physician. I'll even go further. Almost every time it was a Black female physician. I'm tired of us having to be the one to stick up for everybody. I'm tired that when it's our turn for people to talk, everybody is silent. even though this woman has sat there and documented everything? Why is it always us? And then people have the nerve to vilify our strength, to vilify our voice, when you put it on us every single time to have to be the one to have these conversations, to host a Zoom meeting, to be the one to say, hey, excuse me, talk about it. And then I was left and I thought about her strength. To sit there and know you're dying, to sit there and know that you're fighting for your last breath, and you gift us with the receipts. So when you die and they try to say it was something else, you have left the courage. You've taken every bit of courage that it takes to breathe. Because I watched my father struggle to breathe. I watched him use every bit of strength, and she still took her strength to say, I'm going to leave this story for others to fight in this fight with me, even if it takes my last breath. Not only does that speak to her as a Black woman, not only does that speak to her as a physician, it speaks to the sacrifice she must have given to the system, and they betrayed her. And to Dr. Campbell's point, it gave me a sense of energy. It woke me up even more. And it made me say, I'm not going to stop fighting, not only for my father, not only for my mother, not only for Dr. Susan Moore, but guess what? For all the Black lives and Black bodies that have died, that we have no idea what the story is, but it's a story that's just like this.
Sorry, this is Dr. Isom. It's interesting because for me, I am someone who has had to compartmentalize the emotional reaction to medical racism because I've been so invested in speaking about it to majority white physicians. Spending time talking about the history of medical segregation, the ways that Black bodies have been abused, mutilated, and harmed. And then transitioning to all of the statistics that illustrate that the disparities are everywhere and that a big contribution is from physician and other healthcare professional behaviors. And it's interesting because I actually, the compartment broke essentially with Dr. Moore's story. I was pretty much crying for days, and I'm thinking about in anticipation of future talks. I can't see myself being as emotionally numb as I have been in 2020 for these other talks. I'm actually just thinking to myself, like, how can I continue to have these conversations after this story? And I'm not really sure how. And I say that because the people who have been champions in this work have been Black women going into spaces, having these conversations, really harming ourselves in an effort to try to disrupt medical racism in whatever way possible. And the emotional toll of that was really captured for me personally by not even being able to watch her video. I've only seen like 2 minutes of it. I don't think I can actually go back and watch the rest. I think it would just be too emotionally traumatizing for me. So the strength that I thought I had as it relates to this particular topic, I realized I did not. And there's also a lot that I share with Dr. Moore. I'm a fat Black woman. When I enter into the healthcare system, not only my race, not only my gender, but also my size is something that is disgusting to healthcare providers. And another thing that her story motivates me to do is also to talk about fat phobia as well as it intersects with my other identities. So it's kind of like let the dam break for me as far as my emotional experience of being a subject matter expert on the topic. And I really am worried about all of us. I know we're energized, but energized to do what? Subject ourselves to more harm while trying to be change agents in a system that really doesn't care about our well-being. So I would love for us to—
Sorry, miss, I don't hear you.
I wanted to make sure that everyone that's in the audience, that if you're not on the panel, respectfully for those that are speaking, let's keep our mics on mute, as it's a very sensitive and serious topic. I wanted to actually read to you guys some of the statements from the audience. I'm an emergency room medicine doctor who works at some HCA hospital, who essentially keeps tabs on opiates we get for our visits. Many of the other non-Black physicians, nurse practitioners, and PAs won't even give opiates for treatment of surgical conditions in the emergency room because of this. As you would guess, many people of color suffer. It's a fight on a daily basis to advocate for treating pain in one's people. Dr. Obika, we also need to introduce STEM to Black children to ignite interest in healthcare. Joffrey, Essay, I'm afraid, and I fought, and I advocated. I'm educated, and she is safe now. I have no idea what that was, so if
I removed that person from the
TT, can you go and find who that is? So this is the thing. Now I'm about to get heated. So when we have our conversations, there's always somebody that's going to come into the room to try to break up, okay? So we're not going to have that space. We're not going to engage in that space. So if people are coming into the space to disrupt our message, you won't win. Because at the end of the day, Dr. Susan Moore, we still will say your name. There will be countless more Susan Moores out there. There will be countless more Mr. Moores out there. We still will say their names. So to anyone who feels that they will come in and try to infringe on a territory where we're articulating our positions, this is our safe space that we've created for ourselves. You won't win. Not in this space, not in this time, not this season. We shall move on.
I would say maybe you can lock the room and like have people just go to the YouTube from here on out, because yeah.
Definitely.
I was just going to write that in the chat. No more, we're not admitting anyone else.
Yep, no one else. Thank you.
Definitely, I agree with that. Essay says, when you speak out and you still need medical attention, they blacklist you because everywhere you go, you're traced by a number. Insurance, Medicare. Dr. Magdala, I'm so sorry for your loss. I lost my brother due to racism. I was a medical student. He was discharged with a diagnosis of kidney stones when he had a dissecting aorta. I've lived with the guilt for almost 20 years. I'm sad and I'm tired. To everyone, I spoke up routinely for BIPOC. We all know what that means. Patients in Inequitable Treatment in my residency program. The organization was not interested in confronting its racism. Instead, I was deemed to be a problem. How many of us have actually heard that? We the problem in a healthcare institution when we speak up? I was disciplined into being silenced. How many of us have been disciplined into being silenced? Okay. Medicine is oppression by design. It was not made for people of color, whether as providers or as patients. Dr. Nicole, as a physician who now works as a professional healthcare advocate, I was devastated that her advocacy was not enough. That's impactful. I tell my friends, family, and clients how important it is to advocate for themselves and provide the tools for them to do so. Dr. Susan Moore was a strong advocate for herself, yet she still died. And efforts have been successful at a few hospitals. Hospitals in the country will continue to do this, but only if we start at the grassroots level at organization. Is there any advocacy happening regarding the difference in GFR for Blacks and non-Blacks?
Can I cut in here? Actually, because part of that conversation was that as well.
Mm-hmm.
And they were bringing up the point of, gosh, I can't even remember what else they were saying, but they were saying that there's something else having to do besides the muscle mass. And probably the physicians can speak better to this, but I was disagreeing with them, and them being my friends' white roommates. and they just didn't want to hear it, non-responsive.
So
I
one,
have I have had those same discussions and those same arguments. And I even wrote a paper. Everyone should read this book by, Dr. Ima, you know the book I'm talking about, we did the book club in?
Medical Apartheid by Harriet Washington. That should be on every medical student, every physician, every nurse, every medical professional must read that book. That's what you're talking about.
And the reason why I brought that up is because I'm a physician and a neuroscientist. Thank you so much, Dr. Campbell. If everyone sees Dr. Campbell's screen, that's a must-read book for every single body, people in healthcare. And she goes and talks about the historical mistreatment of Black bodies in medicine. The founder of gynecology developed his speculum on unanesthetized Black slaves. That's a tool that I use every single day. And to know the history, to know how some of these vaccines were created on Black bodies without their consent, Tuskegee. And one term that she used, and I use in my paper to talk about the health disparities and dementia in African Americans, she uses the word biological determinization, meaning that race is a social construct. It is not a biological construct. However, since even probably before slavery, we as a society, as scientists in academia, have used research to perpetuate this idea that Black people are genetically different than whites or other ethnic and racial groups. So therefore, my high blood pressure is due to my genes. Pain. She talks about how it was thought that Black people don't feel pain as strongly as other people. Therefore, it's okay to undertreat our pain because we inherently don't feel pain. And it is a flawed concept. It is a concept that stems from racism, but it is part of there's evidence in our medical practice that we're still using this ideology to practice medicine, and it needs to change because it is killing Black people.
Can I just take that one step further? And, I always tell people, like, don't just read. Like, I need you to study this. Like, I need you to study this the same way you study about gastroenterology, the same way you study EKGs, the same way you study it like your life depended on it. And the urgency that we have for all those other things as medical professionals, we need to study this, right? This book, Medical Apartheid, I've read it 4 times. I've studied it like I studied Robbins when I was in medical school. And so there's so many resources in there, and just reading it, I think, obviously gives us sort of a overview of what things are, but to put these things really in context, a lot of the references, every single page of this book has references and all these reports and, all of these historical accounts. Like, you need to read, and then you need to go and you need to read those things as well. And you need to read those things as well and study them and understand them and make sure that you can put it into context, because, because when we now are in a position where we can talk to people and we can kind of share these stories and we can sort of, again, it's about speaking the language for the people who are making the decisions. We need to be able to come with that history, right? We need to be able to come with that data, that we're not just saying this emotionally, because that's what a lot of this has been written off as. Oh, well, of course you feel this way because you're a Black woman. And, I know this is like, personal to you. This isn't personal. Like, this is part of my job as a physician, right? Is to educate. And so for me, in order for me to educate, I need to make sure that I understand the history. So I always tell people, read and study, and you keep studying and you keep learning about this. Because to me, this is just as important as knowing how to read an EKG, because this is a life or death situation for a lot of these people.
This is Jessica. I'm a psychiatrist, so I need to understand why. Like, I have to formulate a problem. And a lot of my research has been around what is it? Like, what is the utility of biological race for white people? And I think history will tell you the story. 1865 Emancipation Proclamation, you release about 4 million previously enslaved persons to the society that's not prepared or interested in taking care of them. They don't give us housing, they don't give us food, they don't give us doctors, they don't give us anything. So what you saw were disparities. You saw that there were increased eye disease, increased dental disease, increased heart disease, early mortality. And if you look at how we were described back then, it's the same way that we were described now. A little bit different. They said, your freedom equates to your death, right? Like you can't handle being liberated because it's not healthy for you. And you were so much healthier when you were back on the plantation. So what they do is they decontextualize your illness and make it about your race, or in that instance, your freedom. And that absolves them of any responsibility back then, of course, except to put you back in bondage. Now, and since then, it's also a really useful tool to absolve them of doing anything about the disparities, right? Because if we are sicker and dying earlier because it's genetically, manifest, then there's nothing for white people to do. If we're sicker because our housing is poor, because our water is dirtier, because our air is not high quality, because our education system sucks, right? How you define the problem, then that would generate the proper solutions. So if the solutions were defined as like a socio-political, economic, like root cause of all of these disparities, then there would be social, political, and economic solutions. So white people giving up biological race is a really big thing for them to do. It's a paradigm shift that a lot of people aren't prepared to do. And I recognize that, and I have to tell myself that that's where their defensiveness is coming from, because to give up biological race is to give up their concept of what whiteness means and what Blackness means. And I'm not saying everyone can do that right now, but there are some people who can. Over the past year, 2020, they've engaged in that paradigm shift, and now they're suffering with us. It's super painful to actually recognize that human suffering is caused because people are making choices, not because of their genes.
Absolutely, Dr. Jessica. And I think the other part that I want to iterate too is we may look at the extremes in our system of seeing racism and injustice, but also look at the subtleties. Don't be a fool. The perfect way to start is even looking at the statement that was issued by the institution and how they described Dr. Susan Moore, right? What do? They dehumanized her. How many times have we seen that on rotations? How many times have we seen that in reports? The parallel is the same thing as when we see Black lives die at the hands of police. What do? They go digging into that record when they were arrested, when they used weed, when they did drugs. And that is the headline. We do the same thing in medicine. The first thing we do is we find things that we can tag on. How does that look like? They were obese, they had hypertension, they had diabetes, they had high cholesterol. It's what we did in the early parts of the pandemic when we had no racial data. We had no idea that our bodies were dying in New Orleans. We had no idea that our bodies were dying in Detroit. We had no idea that our bodies were dying in New York and Baltimore because they didn't want to give us that information. Then the minute the alarm was sound that we were dying at disproportional rates, the headlines didn't say we have to do something. The headline said, Black people are dying because of they have hypertension, obesity, and diabetes, right? So think about the subtleties. It's not only the extremes, it is these subtleties that we ourselves allow ourselves to fall into. And we cannot allow that to happen, because if we don't start looking at the very subtle ways they perpetuate racism, as well as the grand ways, like we see in Dr. Susan Moore's story, we can't fight this system. We have to look at the in-betweens and the things that are written on the wall, because this system, like we've said many times, was not built for us. And my last point is Dr. Mary Bassett wrote an amazing article on reparations. And I know reparations has everybody up in arms, and I just put it in the chat. But reparations as a public health priority is something that we can actually see in evidence of this pandemic. It's not the fact that Black people are sick, get sicker quickly and die quickly. It's the fact that this was the best breaking point to happen because of everything else. And I wouldn't even call it social determinants of health. I'm going to call it political determinants of health, because when we say social determinants of health, it's a nice funny word that people like to use to say, AKA behaviors that are your fault. They're not our fault. It's this the way the country was built. Housing, it's back to nutrition, it's back to socioeconomic status and gaps. So when we talk about reparations, what we're saying that you need to help us close the gap, close the economic gap, so we can stop dying and you can start acknowledging how we were set up to fail, including set up not to be healthy.
Dr. Chery, that was brilliant. I do want us to touch up a little bit more on something that you brought up, and that is the fact that we are even demonized when we are in vulnerable situations. Look at that statement by IU. The staff was intimidated by her. How could someone vulnerable, very ill, short of breath, who's trying to advocate for herself, be told, oh, you're intimidating? I've never heard anything like that in my life. We always, as physicians, we always encourage our patients to be educated, to advocate for themselves. And this woman did that. She advocated for herself, yet they said, oh, they tried to blame her care on the fact that she may have been intimidating to the nursing staff. They weren't intimidated by her. I listened to that woman. I listened to Dr. Moore. She stated clearly that the nurse was really flippant with her. That's the only word I can come up with. If you remember what she said, the nurse, when it was time for medication, she had told the nurse, if you've been in here only once in 4 hours. And the nurse shot back, I can't be in here every 5 minutes. And then she said, well, you were last here 2 hours ago. And he admitted that he was last here 2 hours ago. That's not every 5 minutes. Then he said, oh, I have 5 other patients. Well, yes, you have other patients, but you still have to take care of all of them equally. They weren't intimidated by her. And we hear that all the time as Black women, that we're angry, that we're bossy. I mean, any negative adjective for being strong, they will put it upon us, even in death, even in death. And I was appalled by that statement by IU. How could they say that? There seemed to be no sympathy. And I just can't get that word intimidated out of my head, because we're all physicians. We all will be patients one time or the other, hopefully not too near in the future. But could you imagine someone saying just because of your degree that you intimidate them so they can't provide you the best care?
Yeah, I'm sorry, that was my actual thought when I read that word. And I remember just reading it, and it was, like I said, it was almost like reliving it again. And I'm like, oh, we're intimidating. So a Black woman who's educated is intimidating, but a white person who's educated is inspiring, right? Like that's the words that they use all the time for us. And it makes me sick. And it's when you look at how even, so what I do as a senior resident is I read all the notes that my junior residents write. And we did my hospital did a panel the other day about, patients with sickle cell disease. And part of it was we were talking about how it's actually documented in the chart, words that we use to describe patients, rather than saying, oh, the patient, would like some more pain medication, their pain isn't under, control. Patient is upset because they didn't get enough pain medications. This patient's angry. They use all these negatively connotated words to describe these patients. And it's just like, how dare you? How dare you? But again, this is what we've been looked at. There's a whole historical, there's an entire historical context to this, right? Of how they demonize us, not just in medicine, in every way, shape, or form. We're looked at as the angry Black woman whenever we have an opinion. We're looked at as, too emotional if we call somebody out, and it's these words that hurt, right? And when you talk about healthcare, these are words that stick, and they stick in their medical record. So when somebody else opens up that patient's chart, they read and they're like, oh, this patient's a frequent flyer, and they're angry, and they yelled at a nurse last time because they didn't get enough pain medication. And then that perpetuates the bias.
Definitely. And I also want to add, at the end of the day, even if we assume the very worst of Dr. Moore, the bottom line is she didn't deserve to die. I don't even care. Let's say she was everything that they said she was. She's a human. And I think that you have to acknowledge that you dropped the ball. And the fact that there's no acknowledgement, there's no accountability, I think that is the horrible part of it all. And I really, You know, as a Black woman, I think all of us on this stage, especially medical field, we're used to these things and we're used to walking through life and just dealing with it. But at the end of the day, I think that she already knew what was going to go down. I think she already knew, like, hey, she expected it to some degree. Like when she's in the video, she's like, hey, look, this is me going through this BS again. Because when you look at the articles, she was already in the hospital for her other medical conditions. She had sarcoidosis. So she already knew what was up. So by the time she got here, I mean, she was fed up. And I think her even videotaping it, she was fed up, because for someone to pull out their phone and document it, she probably had experienced this several times before. And now she was like, you know what? This is the end. Let me just do this on my way out to see what this can do to kind of draw out the conversation. But I just feel like, you know, flipping or intimidating, I don't even care if she was. Bottom line, she's a human. She shouldn't have died, period.
And to the point that you made, everything that you just outlined in her care would have been instances, if the person is white, you elevate their care and you say that they are extremely high risk, and you go full throttle, right? Just to make sure, because you're like, okay, this person may not react in the same way as a person who has none of these extra conditions or extra risk factors. And how many of you have taken care of a racist patient? How many of you have taken care of a patient who called you the N-word, who called you everything? And what did you do? You gave the best care possible, like you give to every other patient. So to your point, if she was intimidating, if she was aggressive, I don't care. You still give your best, period.
And first of all, who assigned this word intimidation to Black women? We actually had this discussion about a week ago pertaining to the assignment of that to our agency and our bodies. And so I'm going to tell you my story, and I don't tell my story a lot, but when I do, I had H2N3 swine flu pandemic, which is also, as you guys know, in the SARS family. And I had to go to 4 different urgent cares, okay, within a 48-hour period. I'm gonna try not to cry on this part. So I knew something was wrong with me. And this is why I advocate for African-American people to have an emergency kit and access to a Black Rolodex of people that you know within your own circle that can send you medication, send you whatever you need in the event that you're not getting the care that you need. I went to this huge, huge hospital in Texas, not gonna name them. Saw a top neurologist there, because I couldn't understand why I was having all these issues that were going on related to side effects from what? The H2N3. What's happening now, what you see with COVID. She sent me a referral to psychiatry. Y'all, my specialty is psychiatry. My specialty is psychiatry. So you immediately thought that I was a crazy Black woman coming in there with complaints of headaches, confusion, nausea, vomiting, a temperature of 104.5, heart rate in the 150s, 160s, O2 satting in the 60s and in the 50s. Y'all already know, what is that? Just off baseline. At rest, my heart is going that fast. And you tell me you're gonna send me a referral to psychiatry? So what I did was I pulled out my phone, called my Black Rolodex of my colleagues who know me, neurologists, psych nurse practitioners, family nurse practitioners, PAs, neuroscientists. Hey, y'all, this is what's going on with me. They got me on this infectious disease floor in this hospital. I'm not getting the care that I need. What do I need to save my life? My colleagues in my circle saved my life, not a hospital. So that's why Dr. Susan Moore's death, when I heard about her story, she didn't have to die. Simply because she told them she went in with the same symptoms I had. Anyone who comes in with a heart rate of in the 150s and the 160s and a temp of 104.5 and your O2 sats are going down, you already know that your body is decompensating. And I, just like Dr. Susan Moore, had started documenting on Facebook what was happening to me. My skin was yellow. I was jaundiced by the time that I walked into a hospital.
They had to rush me up to the infectious disease floor. Now, already been there 3 or 4 times. Y'all done referred me to psychiatry, but nothing was wrong with me. Y'all just told me that it was just a bronchial infection. But my lungs were white. So why is it that we don't get immediate access to care? You feel helpless. You feel defenseless. And that's why now, anytime, and this was before, during, and now, that any of my African-American patients come to me and they say, hey, I am in pain. Guess what? I'm gonna look at my Rolodex and I'm gonna find somebody in the state they're in, and hey, I can send you a referral in. Another one of my colleagues, the same thing happened to her. She was only 26 years of age. The doctor gave her 3 to 4 times the dose that she was supposed to have on a medication. Threw her into a potassium overload. Almost killed this young lady. She called me and she said, listen, I'm having these side effects. Look into my Rolodex, call my friends. Within 24 to 48 hours, they had her in a hospital. She almost died. 4 of my friends had babies this year. That's why I resonated with Dr. Campbell's story. I resonated with, I think this is Dr. Chery's story with COVID. All of them the same stories. All of them, one just had to be intubated last week after having given birth to babies. Why do we have to go into systems with an emergency plan of survival? The last place that I will ever go to will be a hospital system moving forward. And that is just me being me. I just want to make sure that I have access to the care and the proper resources and the proper channels for me. And being that I knew that it was you, all of you Susan Moores that are on here that saved my life, I will not walk into an institution. The institution will not be my deathbed. It won't.
Dr. Cash, the thing, I don't have words, and I don't think there could be words besides we hear you and feel the pain that you feel now, and have been probably all of us in a similar position where we had to access social media to get high quality health care. I mean, I've been there when I was pregnant in an emergency room on Facebook in these physician groups saying, these are my blood pressure values. They're about to send me home. Like, is this what should be happening, et cetera, et cetera. One thing I just want to connect what you just said to, and how you talked about, like, how could you be there suffering? Clearly that the statistics are all there and people are not responding to you in a way that makes logical sense. When people talk about diversity in healthcare, the way that I metabolize that is that diversity means there's more people like me that can respond to me empathically, right? You have one group and another group. 2 groups' abilities to connect with each other is contingent upon being connected to each other. We are disgustingly segregated in this country. So we're piping out doctors who likely have never in their lives had an intimate relationship with the Black body, right? So they can be special people and watch TV or listen to the radio or watch a movie, and that's how they develop that empathic connection. But honestly, I mean, all of the social psychology research, you have to actually develop, for the most part, intimate relationships with other groups to have some kind of empathic relationship. So when you walk into the hospital, you don't look like Billy Bob. You're not their aunt, their uncle, their sister. There's just no leverage in your appearance or your background that allows you to connect with them instantly in the same way that white patients can. And this is a part of the reason why I think, besides us being magical, the reason that we're able to deliver better care to our people is because we're from that group. We can connect, we can empathize, we can actually see them without that racist lens, distorting our perception of what's happening right in front of us. But what makes me mad about medicine is that they're not acknowledging that a lack of diversity means we don't have a chance. We either meet one of those lucky people from the majority group that are able to see us for what's going on, or we meet the rest of them. And it's not like white people are evil, or the second largest group is the Asian people of Asian descent. It's not that they are evil. It's that essentially we are set up to be getting care from people who cannot empathically connect with our suffering. And when you go through that medical decision-making tree and you allocate resources and say, this person's gonna go here, this person's gonna go to a psychiatrist, or this person's gonna go up to the floor, empathy is all through that medical decision-making. And I don't understand why we're not having that kind of conversation. So I can understand with all that said, why someone would say, well, why would I access that system at all? And fortunately, we do have a privilege to say, I'm going to text whoever person, and they just so happen to be a healthcare professional. But there are so many people who don't really know one. I mean, my family is lucky to know me. So for those people, I mean, what are they supposed to do? And we could talk about that. But I wanted to put that out there because, again, it's another way of trying to like formulate what it is, because it does not make logical sense that they wouldn't see what you present it with and say, this is what should happen. But they would do the same thing for someone who present it with a different like look. So
that's why your wording of diversity and your description of diversity in its truest form is accurate. I'm very bothered when I keep hearing we need more representation. Represent what? Am I representing your view of what I am as a Black woman? That wording is problematic. And as much as we like to say, yeah, I'm representation is what the person who's seeing that sees it as. So it's not completely congruent to what we see when we say I see representation. When I say I'm happy to be a representation of what needed, I know how I view myself as a Black woman. I know what I bring to the table, but that's not what the other side sees. So when you say we need diversity in its truest form, because diversity to a lot of institutions is a folder that has a lot of different faces that look different, like I'm a fucking photo op, excuse my language, but I'm gonna be accurate. So don't put me on your folder if you're not going to put me in a room so I can speak truth to what you don't know, because I am an expertise in being Black. Matter of fact, I'm an expertise in being a Black woman. I'm an expertise in being a daughter of immigrant parents. So let me bring my expertise to this profession, because you're not going to find it in Robbins. You're not going to find it in Harrison's internal medicine. You're going to find it by listening to me. So I almost want to say part of the action steps is let's redefine what diversity looks like in healthcare. And I don't need it to just be doctors. I need it to be transparent across all levels of leadership, including the CEO of these hospitals that are not getting fired for not preparing these institutions with proper PPE and training to be prepared for a pandemic that's killing more Black people. But no one wants to say it. So let me say it louder so people can hear me. So when we talk about diversity and actually holding people accountable, start from the top. I hate this top down, and all these young doctors know it. You get into these places, you come in with your ideas and your innovation, and what do? They stunt you. They tell you have to publish. And not even just publish one article, publish more. You have to get up on the chair. They create their own standards of excellence and what it looks like to prove yourself, while they break you and take you apart and tell you to mute your voice and don't talk about the Black issues, right? And then by the time you even have a standing chance, you're walking away from medicine. Have you not seen the articles and the people who are leaving? We can't afford to lose them. We lose them, we're done. So when we talk about this in the action steps, let's redefine diversity. And when we say diversity, let's let it penetrate every level of the healthcare system and every facet to give Black bodies and Black people a fighting chance.
Yes, I wholeheartedly agree with that, Dr. Chery. And I, in addition to what you say, pay us for that, because I'm not going to sit here and take my time out. I don't care how many, you give me these academic hours to do this. Damn well this work takes much more time and resources. You want me to publish? Give me the money to do my research. Right. If that's the case. You want me to create protocols? You want me to do all this? Give me the academic time. Pay me for that. Put me in positions. Don't tell me to do this work just simply because I'm Black and you think that you've checked a box and you can walk away and virtue signal and do all these things that you guys do. You need to actually compensate us, because again, a lot of us do this work and we do it for free, right? And they don't have the system set up. And that goes back to what you were saying. There's no system for that there, because the people at the top have their little folder. They can put their, ambiguously, racial person on their website. They can put, the one Black medical student that they have on their website. The hospital gets the PR. Everyone feels good and walks around like they've done sort of their duty to Black people. And it's like, no, that's not what it looks like. And Dr. Isom knows I love this term, pseudo equity. That's what that is. It's pseudo equity. They think that they're doing the right thing. They feel like they are, and they think like, oh, check that box. We're good. All of our Black patients are going to do better. And that's not what it looks like. And we're not saying that it's easy to do. This is an entire systemic change that needs to happen. So if you're doing research, you need to put money into that. If you're telling people to do administrative work for this, you need to put money to that. You need to give them time. You need to give them places where they can actually do this work and actually make a difference.
I
Say-
just wanted to speak to that really quick, because I'm even at the level of the medical student, which is where I'm currently at, I still see this, and it didn't really become apparent to me until so I was very active in my first 2 years on campus with the SNMA and with other organizations as well. But what I realized is that they would call out to me specifically to like participate in these kind of like photo ops. And then when I would see the finished products of the commercials that my school was putting out, and not to like put my school down or anything like that, because they're providing me with my medical education, but I did realize that it was skewed towards Black people who only make up anywhere from 5% to 8% of our classes, period. Like each year I've done the calculations. Like, so to I don't know, they're putting on this facade as if, you know, there are so many, look at us, like we have Black students, we have whatever, you know, Latino students, and I'm like, this is not what our campus looks like. And I don't know, pushing that narrative, it's just like, I don't know, it's leading, and it, to me, is a misrepresentation purely of just what the organization actually is at its center and the problems that exist there.
Yeah, I'll just share a story. So I was applying for jobs this year, you know, for next year. And, you know, a place wanted to recruit me to say, oh, you know, we want you to come here and do all this diversity work, and everything's great. You know, we're really pushing for that. We're really pushing for that. And just to student Dr. Owen's point, so I asked, I said, well, can I speak to some of your residents? You know, and, you know, they were like, oh, you want to speak to residents? I said, well, yeah, you know, I'm going to be faculty. I want to see what the expectations of residents are for me as a faculty member, you know. But one of the reasons why I did that is I wanted to see from the residents, like, if you're telling me that you do all this work in diversity, every resident that I speak to should be able to tell me what you guys are doing for diversity. I spoke to their chief residents. They're like, oh, well, you know, I hear that we're doing something about that, but I'm not part of that. And that's where I have an issue when it comes to the education here, right? You have these people who are training on Black bodies and who are part of the system that you're touting as, oh, we do diversity, we do inclusion, we do health equity, but they know absolutely nothing about it. So they leave these institutions saying, oh, well, I slummed it for a little bit, you know, in this low income area, and they feel like they have that street cred that they could put on their resume for their next job, but they know absolutely nothing about it. Right? So that's when I talk about pseudo equity, pseudo diversity, pseudo activism, like Dr. Chery put in the chat. You know, they say that they're doing it, but they're not really doing it in the places where it really matters.
Definitely. Like, so like so I spent some time within my residency. When I was there, I was actually designated like the token person to actually start a healthcare disparities curriculum, which is a problem in itself, because again, the work is being put on me, because I realized during my experience in residency, there were so many microaggressions and I did not understand it. And I had to sit with my program director and say, what is the problem? And we just got to it. And then I was assigned of this whole humanism in medicine, healthcare disparities, blah, blah, blah. But I say all that to say is that, yes, I did that and it looked good for me, blah, blah, blah. But at the end of the day, it's like, why isn't someone else doing this, number one? And number two, when we talk about diversity and inclusion and all these terms that are constantly thrown around and we don't really know what they mean, you know, yes, diversity, everyone invited to the party, inclusion, everyone sit at the table. But the bottom line is, who is going to do the work? What conversations are going to go on in that gathering? And that's what I always say as a third point to that is like
solving the medical racism problem is not our job. And it's not an effort that we can't even accomplish that goal as like 4 to 5% of physicians being Black. And it's one of the reasons why I say the word white people, that's 2 words, like 50 million times a day, because it needs to be clear that the majority of the healthcare workforce is white. So if medical racism is going to be different, it actually has to be different because the people that hold most of the decision-making power and gatekeeping changed. So yes, system change will be really helpful and useful, but unfortunately also I put in the chat too, it requires a lot of introspective work. And people, again, put their defenses up at even the notion that they are complicit. And I don't even know who that labor is supposed to be, whose job that labor is supposed to be. I've taken some of that on because again, we have to have really honest conversations about what anti-racism in medicine looks like, and people don't talk about introspection very much, even though I think developmentally that's the first step. But I really just wanted to make the point that we are not the majority of the workforce. We don't hold the majority of decision-making power. We're not really gatekeepers. So it's a white people in medicine problem. And somehow, some way they have to be convinced, and yes, the word convinced is accurate, that it's relevant to them, that they have some skin in the game. And I think COVID-19 has demonstrated that, right? Because if 70% of people are not a part of that herd immunity, we're all going to be impacted by that, and addressing racism is a part of that solution. But if there's any white people in the audience, I name you because you have to be named, and I'll continue to do so. And I think we all should continue to do so, because that's the population that really holds our potential for this being successful in their hands.
And to support you fully, Dr. Jessica, white people hold the power in this system, and that's a given. So you gave us this lame ass 5-6%, but the chairs, the majority of chairs, CEOs, department divisions, deans, like the list goes on, they're white. And even more so, they're usually white males. So to the point that we're making, we can't fix this. We literally don't have the money, the resources, and the authority to fix it.
So Dr. Chery and Dr. Campbell and Dr. Ensign, to your point, why can't we create systems that are for us and by us? And I say that because even when this happened to me, I went all the way up to the president of the this is a huge hospital in the state of Texas. So I knew which channels to go through. And still, the president of that hospital supported that particular neuropsychiatrist, it was a neurologist, in her decision not to treat me. So you know what I did? Like I said, went into my Black Rolodex, and I still have it to this day. So I created a system for me, and now I use that system for all of my colleagues that are in my same circle. And I call it just basically having a crisis prevention system for yourself in the event that you're going in for physical issues, psychiatric issues, OB issues. We have to have a crisis plan in place, and or a facility and or institution that's created for us by us that treat people who look like us. Because I've seen too many people recently within the last 2 weeks alone, had they not had access to the proper channels and resources, that they would have died. My sister just gave birth and almost died. This was just last week. So these things are happening over and over and over and over again. And when I tell you that each of these Black women went in with a plan, each of them went in with a plan, and the plan failed them. The system failed them. One of my friends had to save her own life because she knew the signs and symptoms of preeclampsia. She knew what was going on with her body. She had her emergency bag right next to her. If y'all don't give me what I'm gonna get, guess what I'm gonna do? Reach in my bag and give it to myself. And guess what? When the lab work came back, she was right. Had they have been, they were already a day late from what she had already started medicating herself for in the hospital. Why do we have to go through these extreme measures? And I'm gonna keep it real. When Becky and Susie can go up in there and get the most optimal care, the most basic human level care. So I'm saying that for me, I go to providers now that look like me, that can identify with me and what's going on with me. I will only pour my money and resources into doctors who look like me, nurse practitioners who look like me, PAs who look like me, systems that work for me. I will not pour another dollar into another system that does not look like me.
The unfortunate part is the fact that a lot of people don't have that privilege. So to your question, this is when you talk about systems for us, made by us for us, what we really have an issue is a money issue, right? So the other system that I like to talk about that I think is a system of oppression for a lot of Black physicians is student loans, okay? People don't like to talk about it, but I'm gonna talk about it because you talk about representation, but people don't, when my parents were alive, my responsibility wasn't just to me with my money as a primary care doctor. It was also to support my family, right? So a lot of times you're tied to these places, these salary incomes, and you can't even think to be innovative, to think about tech, to think about how you can bring your ideas to another place or even create your own, because you're limited by loans. You're limited by other responsibilities, which is the other part that's not often talked about when we talk about representation, is what does that come with? A lot of us have responsibilities because we are it in our families, right? So when we're talking about building these systems, this is a whole complete conversation. Like, we got to go in deep. It's not even just about, I had friends in school who were white who were like, I don't know what loans are. My parents are paying. Excuse me? What? Do you know how much freedom that provides you to be able to think and really think about how you can do whatever you want? Like, are you kidding me? Some of them had jobs lined up. So it's not even just getting representation like they like to say it, but how are you providing a system for us to come through, bring our ideas, not be tied down by loans, but then really be able to flourish and create systems of our own? It's a money issue. There's multiple levels to this oppression that exists in the system that we don't like to talk about altogether, which we need to.
Right, and I would just say, coming from Howard University, I mean, that was a big issue, for our hospital, which was affiliated with the university, that, treated mostly Black patients, even though it's in the middle of the new, gentrified Washington, D.C. A white person gets shot outside of Howard, they're not going to Howard, they're going to Georgetown or GW. And so, because of that, of course, some residency programs were shut down. The university was hemorrhaging money from the hospital, and so the hospital had to be bought out by a private group. Thankfully, the CEO of the hospital now, through that private group, is a Black woman who, again, I'm not there now, but I'm hoping that, there is this conversation that's going on. And so that's the other part of it, in spaces where we do occupy and where there are spaces for us, there are all the same issues that come up, right? Even on a micro level, there are all those same issues. Because it's a Black hospital, a lot of those patients are uninsured, because of that, the research is not there, which means the funding isn't there. And it's this endless cycle of another Black institution, another Black system that's just not getting money poured into it as much as it can.
I'm so with you. I mean, I work in a health center that serves like 95% Black patients from all over the African diaspora, including people who are not English speakers. Majority non-English speakers are Haitian Creole. And when you sign up for that kind of job, working with that population, that you're signing up for a resource poor setting. And it's resource poor because, again, people made choices, and it's important to keep saying people made choices, because there's a place down the street where they chose to give them more resources, give them more time to spend with patients, give them more support staff so they could focus on patient care, not focus on case management. And we're burnt out. I mean, we are burnt out people trying to serve a population in a context that no one really cares about. So I'm so with you. I'm a mom. I also have family who, in varying stages of getting themselves out of poverty. Some of them are still there. So when I'm making choices about what I'm going to do next, there's more than just me on the table. But I would love to work in a for us, by us system that is invested in, adequately. And that could be a form of reparations. Also, why do we have student loans at all? Like, why am I like
talk about it, please? Talk about it, sis. Talk about it.
Bring it up.
We're trying to do some primary care up in here. Talk about it.
It's crazy. I'm gonna die early.
Go there, but go ahead.
My child is probably gonna, lose her mom early for a lot of reasons, but inclusive of all of the toxic stress of even doing this work. Why am I paying back student loans? Like the only time in this trajectory for me that I felt a little bit okay was the COVID-19 pandemic, where they said, we'll take away your interest and you don't have to pay anything for a few months. This is the only time I felt like a normal person. I should feel like this all the time, right? Like all the time. So I'm totally with you. We could tell a lot of trauma stories just rooted in trying to financially survive the journey. And I'm just like, oh, why are we paying loans at all? Maybe that could be an outcome of this.
Right, and I think also, and I think a big part of this conversation is solutions. And so, there are hospital systems that actually have loan repayment for physicians who are, physicians of color who are dedicated to staying in those areas. I know my hospital system has a loan repayment program where I think it's over the course of 3 years, they give you $40,000 a year as you stay in the system. And so, that's one way that it's being done. but that's not the norm, and that's not the mainstream. And so one of the things that I need to do is I need to figure out how did they get that in place and share that information and make sure that, how difficult was it? Where do you get this funding from? How did you come up with this? Because I mean, that's one of the reasons I'm staying, right? I could have easily gone somewhere and made probably double the money for that and pay back my loans in 5 years. But I said, okay, I'll stay in this system. I do love where I train, but I'm going to stay. But, even with that, right, $120,000, that's not, I mean, it's a big dent, but I'm still going to have to pay back a whole hell lot of money. I have a mentee right now who has $600,000 in loans, right? $600,000 in loans. And, it's about, I'm asking her, I'm like, how did you, like, what were you using your loan money for this? And she's like, well, I took out max loan. She's like, because I got to take care of me and my child and my family. And that's real, and for a lot of people, that's how they decide on the specialty they want to go into, right? They're not going into primary care sometimes, because they're like, oh, well, I'm not going to make that money, right? So there has to be a whole upheaval of the system. It's not going to be a change that's going to come in a day, a week, or even a year, but we have to start putting those things in place. We have to start putting pressure. I'm a firm believer in pressure. I'm a firm believer in tension, right? To hold people accountable to make these changes, because you can't say, oh, well, we're all about this and we want to change this and we're about diversity, inclusion, and equity and all of this, where there's so many gaps in the entire pipeline for everyone. There's so many gaps, even those who quote unquote make it. Well, you're a physician now, you should be fine. No, it's not. It's not fine. It's not fine at all, and it's not acceptable. And we need that tension there. When we have the opportunities to be in those rooms, even though they are far and few between, we have to be vocal about it, right? We have to be vocal about it and let them know, like, somebody's checking you. Don't say that you didn't know. Ignorance is no longer an answer for any of this. Ignorance is no longer an answer. So we definitely have to put that pressure and keep that tension.
Yeah. Sorry, I just wanted to mention, because I mean, while obviously there are not nearly enough resources and places for us to be, one thing that is quote unquote positive that came out of COVID-19 for me is having been affiliated with Black Doctors COVID-19 Consortium. If you've been on any of these panels with me, I've talked about it. It is an organization that was started by Dr. Ayla Stanford, who's a pediatric surgeon, and she wasn't doing surgery. She saw that she's from Philly, so she has that hometown like pull towards the city. She saw that Black people weren't getting tested, that all of those restrictions were really barriers for everyone, but especially even more for Black people. So she started, the organization, and literally the first day we were out there, and if you guys don't know about it, I'll link the website down in the chat, but it's basically, we're an organization that partners with faith-based organizations, and not just Christian organizations, but also Muslim, Catholic. We partner with schools and community centers to do COVID testing, and we've been doing that since April. And I've been super, proud to be a part of that, this organization, because of what it's blossomed into. It's not only just COVID testing anymore. Now we're talking about, opening a clinic, for, she already has a private practice, but that's her private practice for pediatric surgery. So just building this into a system that actually is healthcare for us in the long term here in Philadelphia, because she's been able to gain so much trust in the community, and I guess us of an organization in the community, because we're here for those people, and people will literally come out 2 hours ahead of time, stand in line, 650 people in one day, one time, 400 people another day. Leading up to Thanksgiving, it was crazy. We did 1,500, tests, and also capturing those people who, because we did flu shots as well, and up until I think January 15th, we will be like capturing those people who wouldn't have normally gotten a flu shot to, get those flu shots, and also doing antibody testing, which actually a lot of the data that they're purporting in our population, which is 95% Black, actually isn't true. Most of the people who got sick didn't have all of those coexisting conditions, and the ones that did, it was mainly just hypertension. I mean, not just, sorry, that's a big one, but so when I hear these things, and yes, I know that our it might be population specific, but when you have a population of over 15,000 now, and we're seeing these things, you have to question what they're saying, and especially how early they're saying it, because we just been doing this since April. We just, you can't possibly make these broad speculations based on just the time point alone for me. and especially we're finding differences, sorry, this is just a tangent, but differences with the antibody data. We've been testing our patients at 3 months, 6 months, 9 months, and finally LabCorp came out with the titers. And what we're finding is that the people that had 100% of the people who had antibodies at 3 months have them at 9 months. And that's the April-May population that we just tested, and that the titers are matching. So they're sticking around and they're the same, the same amount. The sensitivity only goes up to like 250 units or whatever the measurement is. But yeah, so basically it's I don't know, that's all I wanted to say, that we can do these things, but it has to not happen in a microcosm. And only got government funding, about 4 months in. So Dr. Stanford, who again is a pediatric surgeon, so Dr. Chery was saying, or I think even Dr. Isom was saying, or I'm sorry if I'm pronouncing that wrong, it's like she's making, probably into the $600,000, $700,000 a year. And so she had the money to grassroot this herself. And she was paying out of pocket for the first 3-4 months until we were finally able to get the government, the Philadelphia state government to the Pennsylvania state government to recognize what we were doing and say, hey, you guys need to fund this. We need the money. And so finally we were getting, it went from a volunteer situation for me during my research year to being a full-time paid, research position, helping patients, on the front lines. So I think that we can do it, but it's just you have to continually fight. And she is a strong person, but we can't do it alone. So we have to, I don't know, continue to band together. But again, this is just a microcosm because this is not just Philly, but I don't know how it can happen on a greater scale, or if it just needs to be in these smaller cohorts.
And I think what you're talking about, student Dr. Owens, is just this concept of, we know what we need in our communities, right? We can actually be the answer our communities need. A lot of times it's the other stuff that's holding us down and not allowing us to really be fully present when we can actually be the answer that our community needs. So I think going back to why we even came together as we're holding space for Dr. Susan Moore, it's not just about fighting racism in our system, but the hope is that it's bringing us together to channel our greatness, right? Channel our greatness, not just in just passing the board exams and getting board certified, which are important, but channel the greatness into saying that you understand your community better than anyone, right? And the Black community is not a monolith, right? So there's many layers to it. So we can't just shut our mouths and not understand what we bring to the system. And we have to sound the alarm to say, hey, the way we're approaching it is not going to work for the Haitian population. It may work for here, but it's not going to, I'm telling you, as a person who comes from Haitian parents, there's another level of how it has to be done. And this is why it's so important to not only fight, or I should say, sound the alarm so white people can fight racism and change racism in our system, but also sound the alarm to elevate our voices, to give us power in this system, because that's the other form of oppression that we have to also fight. We need that power and that authority so we can be the change, so we can create, because it doesn't exist, so we can create a system that actually thinks about Black bodies in mind. And I think that's the message that Dr. Susan Moore is probably thinking when she's literally documenting her death and documenting everything that's happening. She's probably saying to herself, I may not live to see what happens with this information, but maybe if I can drop it, it can inspire someone to say, not only just fight for my life and fight for the other Black bodies, but more than ever, your voice is needed, your power is needed, your authority is needed in this system. So fight for it. Fight for your chance to speak and own that space, because your community literally depends on it.
Thank you for saying that. And I totally agree. I just wanted to answer the question that that Mr. Wilson asked. And the answer is yes. Leading up to the the emergency use authorization of first the Pfizer and then the Moderna vaccines, we held town halls that people attended from the community to talk about the vaccine and educate people. So yes, we are doing that as well.
As strong, powerful Black women in these healthcare fields, listening to my colleagues, I almost just wanted to break down crying. Not only are we taking care of our patients, taking care of our family, and now we're also trying to make sure we continue to say Dr. Susan Moore's name. I'm suffering mentally. This work it's extremely difficult work. And several people said, it's tiring. I've been doing this work for a long time. Dr. Erica Littlejohn and I, back at our previous institution, we held movements for different reasons because Black people were not being treated right. And again and again and again, we're doing these town halls, we're holding these movements, we're holding these meetings, but who is holding us? This type of work took me to the emergency room. It took me to the emergency room. And yet we still keep doing this work because I know no one else is going to do the work for us. When I was disheartened to see that when I searched hashtag Dr. Susan Moore's name, there wasn't a plethora of other posts. The news media isn't talking about it. I haven't seen or heard other medical institutions or societies put out statements. And I've been asking, please say something. And so when I didn't hear this, we put out statements. I mean, this is our movement. This is our statement. We are the ones speaking up. We are the ones who are suffering. And I am tired. I am tired. And tomorrow I have to go to work, go to the system that is oppressing people that look like me, put a smile on my face and treat my patients. But who is taking care of us? Who's treating us? I kind of want to put that out there. How are we taking care of ourselves during this movement or with these issues?
A therapist.
I was gonna say, I'm in
I was just gonna say the same thing.
I got therapists. I got
Do not
therapists.
disturb. No, but definitely, I think just
for real.
Yeah, I mean, definitely therapy. I think everybody needs a therapist. I think it is one of the best things ever that I had ever chosen to do. And, you know, like Dr. Chery, I am West Indian. I was born not in this country. You know how we feel about therapy already, right? But I said, you know what, F it all. I'm going, I'm showing up, and it helps so much. But then also disconnecting. I mean, I think, you know, especially with social media and all these different platforms we have now, Clubhouse, you know, I tell you, it was taking over our lives now, but definitely disconnecting. And I think it's such an important part of just taking care of ourselves. You know, I love this work. I love what I do. Sorry, I live across the street from the hospital, so y'all gonna hear this all the time. But you have to disconnect, even if it's for an hour a day, like disconnect and not sort of be thrown in, because a lot of times, even though you love this work, the more you read about some of these things, it's traumatic to us. You know, it's like this kind of subconscious trauma that we have, and it's some things are triggering. You know, I sometimes, you know, before I go to work, I'm like reading or listening. So I get to work, I'm like side-eyeing all the white people, and I'm just like, like I'm angry at y'all, and you know, what you looking at? Like, no, but it's real though. Like this is for like really what happens, and you know, we don't realize how much of it we actually internalize and how it's actually just like killing us inside. And you know, there was an article that came out the other day on ProPublica, and it was talking about how, you know, we are so hyper vigilant about discrimination and about how we're treated that it actually is killing us. It is actually killing us, right? And so it's hypervigilance at baseline in your every single day, where you gotta wake up, think about, how am I wearing my hair? Let me make sure when I go to work, I dress properly, that, you know, I don't say the wrong thing, or I don't talk too loud, and you know, I don't do this and I don't do that and I don't do that. But then on top of that, you have to then show up as a physician and deal with all the other things as a physician. Let me make sure that I wrote on my notes, that I'm not killing my patients, that I'm, you know, saying the right things, that I, you know, that I did everything. So you're trying to check all these boxes and walk all of these fine lines every single day. And then after that, you're doing this work and you're reading about it again and again and again and again and again. And so you exhaust yourself emotionally and mentally, and then it turns into physical exhaustion. And then, like I say, how do you show up for yourself when that happens? You know, how do you take care of yourself? And so one of the things I've tried to do, and I'm definitely not an expert at it, and I'm still working on it, is just disconnecting and self-care, and just staying away from it. And it's not that you're trying to be ignorant or you're trying to pretend that this stuff doesn't exist, but you need a mental break from it sometimes, because we're living it and we're trying to change it at the same time. So you're living it, waking up as a Black woman, just trying to exist in this world, in your own world. You're trying to exist in the world of medicine. You're trying to exist in the world of making this change, but you need to take care of yourself. And sometimes I feel guilty for it, but we need to kind of let go of that. Like, you shouldn't feel guilty for trying to take care of yourself, because if we can't show up for ourselves, we can't show up and do this work properly.
I would also add, I mean, for me, and I could be crazy and crazy actually is a disparaging term. I could be taking a risk, is speaking truth, like, and not caring what anyone feels about that. And I'll say I have the privilege of not really being in academia traditionally, in a community health center where people, give me a second, welcome reality. But speaking truth means naming things as they are and calling people to do something about it. And not everyone has the privilege to be able to do so, especially in academia, where of course it's an oppressive context. But I just appreciate, for me, it's a healing thing to just tell people like it is. Like, it actually, I feel like maybe lengthens my telomeres just a little bit, like, or maybe I get like 1 day back of my early mortality by just keeping it real. And everyone can't access that. But for those who can, I mean, that would be my suggestion, is just try like speaking your truth. And maybe that's a form of self-care if you have that privilege.
And community, right? So the other part is community. I think that's why COVID has been so devastating to us, right? We live, we heal together. I think about the times my mother has gone to the hospital in the past. Prior to the pandemic, we were all up in there, like sleeping on the seat of the bed. Somebody was in the chair, mom was in the bed, because there was a part of just being next to each other. I mean, we could take it back to slavery. Even when we were being brought to this country, we were wrapped around each other, right? We were attached. So there's a thing about community that has to exist. So you can work in the system, but this doesn't have to be your community. Go back to, like, I have tribes of chats. So when I get a sideways email, I'm like, yo, come read this. Like, real quick, let me get petty with you real quick. I know Michelle tells us to go high, but I go low quite often. I just don't go low publicly. And I let my spaces help me remind myself who I was before medicine, because medicine will change you. It will make several attempts to change you, and you have to make several attempts to reclaim that power back. So I keep my chats from people that I know growing up, my friendships from people that I know growing up, and what I call them tribe. The people that roll with me, they are my people. That is how I made it through last year with my tragedies, that I find space and time for, to continue to feed my spirit as well as my faith, because that's the only way that I'm going to keep on going and be able to fight, is to fill up my source and take care of myself and live on do not disturb. I don't care, but that's where my phone will exist until I can keep my peace and protect that, so I can feel recharged in this system. And I'm like Dr. Jessica, I have learned that I'm going to be petty. I'm going to own my pettiness. I'm going to call you out. And if that means, to be honest, there are certain jobs I don't get offered. There are certain places I'm not allowed to be in. I'm okay. I'm going to own that. I actually have learned to be okay. And I know some people may not feel comfortable with that, but that is what Dr. Chery has decided is for herself. If my truth scares you from giving me the position, I didn't want it anyways, because when I sat there, you wouldn't let me speak. So I'm going to be freely myself with my big hair in your room. And if you can't accept it, bye. I'm okay.
Yes, love it.
We have a question from the audience. We have a question from the audience from a resident. They wanted to know what should incoming residents be mindful of going into such systems? I'm saying right now, it's something you can't prepare for. We actually talked about this, what was this, a couple days ago, regarding imposter syndrome. And I gotta tell you, I gotta agree with Dr. Chery, Dr. Campbell, Dr. Isom on here. I haven't gotten a lot of positions, so I created those positions for me. So if I feel like a system is not working for me, I'm going to go create a system for me and other people so that we can create these systems together collectively. Because a lot of the times, and I actually did a pilot study on just on the people that were around me. I was the only African-American clinician that was on this team of forensic psychiatrists, and they had never had somebody that was African-American on their team. We're talking about a state that is 97.5% white, okay? So you can kind of narrow that down which state I was in. So I was quiet for the first 6 months on purpose, didn't say a word. I kept my hair in a bun, didn't wear lipstick, just was kind of like, okay, you know, just trying to see what was going to happen. They created a position for me there at the facility because I was just, you know, boom, this is what we need for you to do. This is what we need you to implement. They want our skills, but they don't want us. Just need to hashtag that. So I get into this position. And so now I have to work closely with every single person who is not like me and of the same skin tone within a week of me being in that position and me actually having a voice. I was fired from that job. So I was good for the first 6 months, but now you get me in a position where I got a voice. And now others that cannot identify with my level of implementation, my voice is the same, my tone is the same, nothing's changed except the position. So what I said that to say this, and a lot of the facilities and systems that I've gone into, when I've met a hiccup, it's been through the system, the systemic oppression, when I'm going up the ladder and I'm going faster than my colleagues that don't look like me. All of us on this panel are amazing African-American women. And the first thing that they want to assign to us is the language of intimidation. I don't have to walk into the room and say anything. And they're immediately going to say, oh, you know what? I'm intimidated about her. She makes me very uncomfortable. I just don't understand her. She's very confusing. What's confusing about? I'm very clear.
She doesn't know Black people. That's why. That's why you're confusing her. She don't know Black people.
How we confusing now? You know? And it's like either I turn it on and my voice is like this, or I can talk to y'all like this and it'd be okay. Why do I have to code switch just to get my point across? Why do I have to have a patient to call me an N-word? I had a patient to call me an N-word for 6 months straight, and I still had to give care. 6 months straight. And I go and I tell, like, hey, superior, I don't feel comfortable with this. I can't, you know what? Somebody else can take this patient, but I'm not going to take it because you're not going to keep calling me that, right? No, you still have to give care. You still have to give care. Do you want your job? I don't need this job. So guess what I did? I quit and I started my own company. I started my own resource. I took my own money, collectively got with my other colleagues and said, hey, do y'all want to build a community clinic? Let's do what we need to do. Because I'm not going to be continuing to work for a system that every single time that I'm trying to implement something or I articulate something or voice my concern about something, I'm met with resistance and pushback every single time just because of the color of my skin. So to answer your question, I know from my lens, from my point of view, you're always going to deal with this throughout the duration of your career because we're excellent. And when you're in the midst of excellence, sometimes people get uncomfortable with that. And just like you said, they'll say, I don't understand her. She's confusing, or I don't understand him and he's confusing. No, we're not confusing. We're just powerful. And in the midst of that, you cannot determine what your limitations are and what your strengths and weaknesses are. So you go into your white spaces and create white knowledge for your white people to educate them about us. And that was to Dr. Chery's point. Why y'all hiring us to tell them about diversity? We have been oppressed long enough. We have to learn about y'all. We have to learn about our oppressors, okay? So you learn about us. So why do I have to come into your system, educate y'all people about my people, about the things that you're already oppressing me about? And then like Dr. Campbell said, I still got to show up to work. I can't fake. I'm not a good fake. I just can't fake. So because of that, I'm very vocal, but I can say it in a very nice way. But still, our passion is being misconstrued as aggressive, as too much, as you're too masculine, too much masculine energy. But let me tell you, I had a white colleague that said, Lord Jesus, let me tell you what she said. In front of everyone, I am going to burn this building down in a meeting. I don't know about y'all, but had I said that in a meeting, I would have been gone, right? She's still there and she's still employed. What's the difference there? We are going to continue to face these medical adversities. It is. The answer is, okay, what are we implementing now to make a difference so that there aren't any more Dr. Susan Moores that have to go through this? And that's through the implementation of systems that look like us. And Dr. Campbell, I know that you said earlier in regards to, yes, we do have African-American hospitals that exist. And I have worked at one before. And let me tell you, I enjoyed it. Because at least I knew, let me tell you something, when I was sitting at the table with the CEO, the chairs, and I could still be Taaka, just Taaka. And I could be passionate and I could be brilliant. And everybody else in the room was like, okay, cool. Nobody took offense to it because they understood the language of our culture. And I appreciated that more than anything because I wasn't judged in that space. But anytime that I'm going to any other space, guess what? We got a code switch up. Hello, how are you? Great day. It's been amazing. Hi, Julie. And that's hard. And we do talk about complex post-traumatic stress disorder. That's a real thing. And during COVID, I've seen a lot more patients on the psych side that are still experiencing this. It hasn't gone away. It won't go away. And we need to come up with new, better strategies for our community as a collective.
Yeah, I think that was amazing, Dr. Cash. And I just, I want to address, in terms of residency and, how do you go about it? So there different points, right? A lot of my mentees, are, they're applying for residency right now. And, and I tell them is, you have to make a decision, unfortunately, as a Black person when you are applying for residencies. A lot of times you're going to have institutions that want you because you are Black. There is only, and I'll speak specifically about my specialty. So there are only a few Black people who are applying for emergency medicine right now. So every institution in the country is looking for them, and they're pulling from the same pool of people. And there are some institutions, that are, that are not historically diverse, and, they want to have that first Black resident or, one of few. There are institutions that are historically diverse. My institution is one of those, and so for us, it's like, great, like, we know that we're going to get a certain number. But what I tell people, some people are like, oh, but I really love this institution. It's got a great reputation, but, I'm scared because I'm going to be the only one. And so what I tell them is you have to really, it's a real personal decision, right? I personally was in that same position. And I said, I couldn't go to an institution where I was the only one. I said, because for me and the way I operate, I need to feel comfortable so that I can thrive. And I wanted to go to residency so that I can thrive. If I was in a place where, like Dr. Cash said, where I couldn't voice my opinions, I couldn't wear my hair the way I wanted to, I couldn't talk the way I wanted to, I couldn't listen to the music I want to listen to, I couldn't eat the food that I wanted to without somebody side-eyeing me or making me feel that what I'm doing is less than or, weird or whatever, because they feel uncomfortable, I knew I wouldn't thrive there. But if you feel that that's for you, then you go there. But just remember, don't go there and be naive and feel like, oh, because I'm the only Black person, they're going to put me on a pedestal. They'll put you on a pedestal when it feeds their interests, when it looks good for the PR for the hospital. But if you have an issue, you need to second guess now who are going to be your advocates. If you are in a patient's room with your attending and that patient says something just out of pocket and they call you the N-word, is that attending going to step in for you, right? And you don't know that before you go to residency, but what you can do is you can reach out to other residents who've been at that program, Definitely reach out to other Black residents who've been there, ask them what their experience has been. When I was rotating as a medical student, I was at an institution that I really wanted to go to. It was well-renowned emergency medicine. You'll get the best training here. As a med student, the chief resident walked out of a patient's room who was upset because they'd been waiting long and said, I'm tired of all the Shaniquas of the world. This is in front of their attending, the program director who was in attending that night. I looked around like, wait, like she looked at me dead in my face. She looked at everyone looked around.
I had to be right there with you.
Said not a word. And again, and it puts you in this weird position as a medical student. I'm like, do I want a job next year? Or like, do I really want to call this woman out? And unfortunately, I didn't have the courage that I had now. But if that was me now, I would have turned her whole world upside down. And that, because that but that is what happens, right? And you need to remember that when you're in these spaces where you're not represented and where you don't have advocates, that will happen to you. And so that's a decision that you need to make. And so then let's say now you're in residency already. And I think the question was probably from somebody who's in residency already. The first thing you need to do, and I think it's what Dr. Chery talked about, you need to find your tribe when you're there. A lot of these institutions do have Black student unions. My institution did not have one at the time. But what we did is, let's say you're in, like I said, I can speak from an emergency medicine point of view. Find people within your program, find other residents of color outside of your program, right? Make sure you do that, because that will give you it makes such a difference, right? Make sure that you seek out those residents and you have a conversation, because even though, they may pass you in the hallway, give you a little head nod. And what I used to do, I used to stop and like, hey, you, Black person, let's exchange numbers. We're going to be friends. I don't care. We're going to be friends some way, somehow. We need to talk to each other, right? We need to have these spaces, and make sure that you have those spaces where you can talk and where you can be yourself, because if you don't have space to be yourself, you're not going to thrive during residency. And residency is hard enough as it is. Residency sucks, right? So find your tribe, find those advocates, make sure that you reach out. The other thing that I'm going to tell you, if you haven't applied for residency yet, a big factor is if your residency has a union. I'm very involved in our resident union. And when it comes to things like, retaliation, evaluations, things, when it gets to that point, if that is the worst case scenario, you need to make sure that you have people behind you, even though they don't look like you. Resident unions, again, they're not perfect, but it makes a big difference. So if you can do that, make sure you do that. But like I said, again, make that decision if you're not in residency yet, but then also make sure that you have people who are advocates for you at your program.
That was a phenomenal question.
And I can respond really quick to something Dr. Ebong wrote on in terms of advice in the chat.
Go ahead.
It says, all skin folk ain't kinfolk. Be wary of the Black colleagues who love to be the only Black person in the room and won't help fight for you. Believe this. And yes. That is at the medical school level too, because I mean, I'm always, like Dr. Campbell said, gung-ho to find the Black people, like, what's up, let's get together, like, let's make sure that we're there for one another. But there was another, I was on student council, and the president, she was the president of her class, which was the class above me. So, I'm trying to like get in and like, hey, like, what's up? Like, what's going on? And she wanted to be the only Black person in that space. She wanted to be the only one thriving. And finally, when I realized that, I was like, wow, like, there are people, because that was really the first time that I had that I experienced that. Like, you don't have to be the token Black person. Like, right. There's room for all of us at the top doing different things, striving in different, having different skills. But that was the first time I really experienced that, and it was heartbreaking.
Call it out. That's what you do. You need to call that out and let them know, like, look, cool that you want to be the only, but you shouldn't do that, and that's not going to help us. But definitely, like, I wanted to say it, but I didn't know how it would be received. But yes, when I talk about finding your advocates, also make sure you know that some people are not about Black solidarity, right? They want to be the only one because they want to be that face, right? And that's a whole nother conversation we can have about, in the Black community, those types of people and how they actually hold us back, and sort of the personal and I think psychological process behind that. But again, call that out, and at the end of the day, you can't control the issues that someone has, the insecurities that they have that makes them want to do that. But like I said, at the student level, call it out, but don't let that deter you at all. Do not let that deter you. Make sure that you seek out and find out who are your advocates and who's going to help you and who's going to pull you forward. And also, the other part of this is make sure that you're reaching back, right? Because I think that is a big issue in our community. Again, we've talked about so many different things, but that's a big issue in our community. So many of us make it to the top, and we've made it to the top, what seems like a lot of times in a very isolating way, that we didn't have a lot of help, we didn't have a lot of mentors. But like I tell people, be the mentor that you think you needed. Please reach back, find opportunities for people. If you've written 10, 20 papers and there's one paper, throw a student on it, throw a resident on there, let them be the second, third author. If there's an opportunity, give it to somebody. Like, please, like this is how we continue the pipeline, especially through medicine and through a lot of other things, but where we can, and I keep telling people, use your platforms and use your resources. If you have a platform to bring more people on, bring them on, put them on, show them how to do the work, show them how to navigate these spaces. Because a lot of times, especially up and coming physicians, they don't know how to navigate these spaces. Even for myself, I'm a resident. So next year I have faculty members now, and I'm so grateful for them. There's a group of 3 Black ladies at my program who have just taken me under their wing, and they're showing me the ropes. When it came time for my contract, they were like, let us read your contract. Let's see this is what you need to ask for. This is what you need to do. It comes down to real practical stuff like that. So please, and Dr. Chery said it before, find your tribe, maintain that tribe, and reach back to them, please, and reach back and mentor.
Can I mention a question, actually, that somebody said in the YouTube chat?
Sure, Casa. Hi.
What's up, y'all? By the way, this is such a needed conversation, and I'm really appreciate all y'all. The question was, after this call, how would you all suggest white physicians and students interact with Black colleagues in a way that gives them a voice to discuss, but does not perpetuate burden of having to educate us?
I'll just start quickly. Sorry, I'm Ben. I'm one of the medical residents in Newark, New Jersey. Work with majority Black population, so super fortunate to have that, and also a good amount of white colleagues as well. And so to answer that question, I would just remind them to, when they're in their groups, when they're starting rounds, remind them, say, we have all contributed to a situation like Dr. Moore's. We have all been a part of, we have all enabled situations that are similar to Dr. Moore's. And just reminding their friends that they are part of the problem, and not ask for an answer. Like, don't answer me. I just want you guys to realize that we are part of this issue. And then another thing is, because medicine and academia, we love guidelines, is reminding whoever your supervisor is that's trying to make a decision, that the guidelines say subjective criteria count. So if a patient is telling you they feel short of breath or they feel in pain, it's not your job to be some type of human behavior expert and try and figure out who's lying and who's not. No, the guidelines say follow the subjective criteria. They said they'd have these things, and so therefore we treat them based on that. And then a perfect example is pain, where like majority of the pain, the opioid epidemic came from outpatient medicine. So if you're a resident specifically, most of your work's probably going to be in the hospital. And remind them, if patients in pain in the hospital, they need to get medication until their pain is resolved. And that is not, you're not going to start somebody's opioid addiction in the hospital. More than likely, you're not going to. And then also B, you're definitely not going to be able to make someone who's already addicted to opioids not addicted in their 4-day hospital course either. And so I think that it's important for all residents to bring those things up, but definitely for white voices talking to other white voices to remind them, like, listen, we're supposed to be, following the guidelines as such, and reminding them that we're part of the problem in the first place.
Hi, everybody. My name is Dr. Ruth Arumala. I am a obstetrician gynecologist in Mansfield, right outside Dallas. I really love this conversation. I've only been on for a couple of minutes, but I wanted to talk about the last 2 things that everybody talked about, starting with the last one. So I'm the head of the OBGYN department at a new hospital. Obviously, that makes me the only Black woman on the board, executive board, and I have the CEO is actually a Black man. That being said, there's a lot of things that are actually, when you sit and you listen, our community is not taken into consideration at all in a lot of decisions. So when you sit on those boards, when you sit in those rooms, you start to realize that your voice is so necessary, and that made me have to cultivate a voice. So I want to encourage anybody in training to really start to learn how to cultivate your voice. I think back to when I was a resident, and when they would I started realizing that Black women were being told that basically their family size was being kind of influenced by physicians. And what do I mean by that? So someone will have 3 kids, and we would really, really enforce their family planning and their birth control, right? Like, why are we doing it disproportionately for Black women versus white women? Like, that doesn't have anything to do with their actual health, right? And who are we to tell them that they can't have any more children, even if they've had 2 C-sections or 3 C-sections? That's not our business. So I started challenging that in residency. I started challenging it as a chief resident because it took me a while to cultivate my voice. So I encourage you to really think, like, when things are happening, think about, why are they happening in this way? When you notice something, think about it and start to challenge those ideas. And then the second thing I wanted to talk about was how people talked about reaching back. I think reaching back is actually a cop-out. I think that one of my friends says, you know, when you take the elevator to the top floor, you got to take it back down and bring somebody else up with you. That's a little bit different from reaching back. That takes a lot more effort, you know, like really showing people the ropes, really going back and being like, I'll take you there because I hope to God that you stand on my shoulders and you get beyond what I have been. And a lot of the times we don't want to do that because that means that person, if somebody's standing on your shoulders, they have superseded you. But that is actually the strength of, that shows.
Thank you so very much for that. Thank you, Casa, for allowing the people in Clubhouse to also ask questions and bring it to the.
Can you unmute Casa? Because for some reason I think it cut it off.
Mute Casa.
Yeah.
Oh, she had just finished her question, actually.
Okay, I was just making sure because it just.
No, I was confused too, but I was confused too. But she had actually just finished when.
Okay, thank you so much. We wanted to make sure that her whole entire statement got heard.
Yeah, of course.
And this conversation has been so powerful, impactful, and it's really been. At first, when I saw and heard and read about her death, my hope was diminishing. And after this conversation, my hope is coming back. And so to close this out, I would like to ask the panelists, what is one thing you want the audience to remember from this conversation? And know that we will be having multiple conversations on this topic throughout the year, because we want Dr. Susan Moore's voice to continue to be heard, not just today, not just yesterday, but for the remainder of time until the system changes. So what is one thing you want to leave the audience? Dr. Ima.
The one thing that I would like the audience to know is that I definitely am here fighting for you, and that we are all here fighting for you, and we're not going to stop. And I have committed myself to this, and I'm sure the rest of my panelists would say the same thing. So if you have questions, I know Dr. Ighodaro said that our contacts, I know I posted my Twitter to some people who asked me privately, but my Twitter handle is at Ima Ebong MD. So, and I can put that in there. If you have questions, I'm here, we're all here, and you know, we're gonna continue to fight.
Thank you, Dr. Ima. Student Dr. Owens.
I guess the last thing, I was trying to think hard, but the one thing I would want to leave everyone with is that we always need to stick together, no matter what the forum, no matter what the situation. Because one thing that seemed to be a salient theme in a couple of other spaces where we had similar conversations was that, you know, Black doctors or doctors who are, or healthcare professionals that were persons of color were the enemy, government pawns, all this kind of, you know, stuff. But we are not here because we want to further the rhetoric that's already here. We're here because we want to change things and we want to be a part of that change, and we want to do that so that you, even us, can benefit from that. So that's what I would say. Let's just stick together.
Thank you, student Dr. Owens. Dr. Cash.
I would say have a crisis plan in place for when you're going into any healthcare system, urgent care, for your physical and also your mental health care, and not wait until the last minute to do so. If you need resources for that, you can email me personally at taakacash@privyoasis.com. You can go to my website at www.drtaakacash.com and or follow me on Twitter at TTalks with Taaka or Taaka T. And I can answer all of your questions respectively there in regards to what should be included in your crisis prevention plan prior to anything happening to you, whether it is on a physical level and or a mental level.
Thank you, Dr. Cash. Dr. Campbell.
I think, so many things out, that I want to leave with, but I think it's, for everyone here to kind of use your platform. That's something I hold myself accountable for. If I'm in a position where I can speak up, where I can say something, when I can make a change, when I can just offer something, I make sure that I speak up. I think, don't be afraid of healthy tension. And there's a book, and I was trying to think of the name of it, and I can't think of it, but I'm going to send it to student Dr. Owens to put on the resources. And it talks about healthy tension and sort of how to do that. And I think that's definitely important in these spaces, where, we don't want to be passive about this. We've been passive for way too long. And I think we definitely need to be active and really put the pressure on there again. And it's where we have this power and where we have these positions, when we get a seat at these tables, and I hate that term seat at the table because some people have heard me say, I just want to break that table and just redo it myself. But, we need to start at having a seat at that table. But when we do that, we really speak up and we really, come with the research and come with the data, because, the people at the top, unfortunately, a lot of times that's what they understand. And so we need to learn how to kind of speak that language and say, well, this isn't just emotions that are coming out. Emotions obviously are the motivating factor for us overall, but there's real data. There's real data out there. And so if you want to sit there and be ignorant, you can't be ignorant anymore, because it's out there and it's peer reviewed and it's published.
Thank you, Dr. Campbell. And soon to be student Dr. Jackson.
Hello. I just wanted to add that situations like this that happen to Dr. Susan Moore should be an encouragement for future doctors to come, and all of those that are part of aspiring MDs, for them to look at this as more reason to get into the health field and to get into medicine, to be that change. Even though we make up such a small percent, the more that we support each other and believe in one another and kind of have these talks and make these conversations known, the more we can have a change and an impact down the line. So that's all. I don't have too much to say. You guys made several good points tonight, and I look forward to having these open and truthful conversations with you guys in the future, and making the change little by little as much as we can.
Dr. Cash, provide the closing remarks.
Once again, I would like to thank each and every facilitator of this dialogue. We would all like to thank all of you who collectively came together as one solid unit and one solid voice. Dr. Susan Moore, although a tragedy, we say your name. Now, the next thing that I'm going to ask you guys to do, I want you all to make sure that you have no background noise or as limited background noise as possible. We're all going to unmute our mics simultaneously, and we're going to collectively say, Dr. Susan Moore, we say your name, and we're going to say that 3 times. Okay? Everybody unmute. All right, unmute, unmute, unmute. Let me go to page 2. Unmute, unmute. All right, we're there. Dr. Susan Moore.
Susan Moore.
Dr. Susan Moore.
Dr. Moore. Dr.
We
Susan
say your name.
We say your name.
We say your name.
You say your name.
We say your name.
Dr. Susan Moore.
Dr. Susan Moore.
Dr. Susan Moore. We say your name.
Say your name. Your name.
Dr. Susan
Moore.
Dr.
Dr.
Susan
Susan
Moore.
Moore.
Say your name.
Say your name.
We say your name.
That almost made me want to cry because her voice, her advocacy, her contribution. Susan Moore was more than just a physician. She could have been one of us. And we still will say her name. This will not be the last of the series. You will be hearing more from us on the tragedy of Dr. Susan Moore and how we can prevent this from happening within our communities. We'll be talking about the racial disparities that exist amongst our communities and how we can come together to implement sustainable systems to prevent incidences like this. We'll see you on next time. Thank you for tuning in.